the pathological analysis, and to see if the data will change or it will still remain the same. This is still ongoing. We've not had the final report. Also, we realized that we need to build capacity of our HCPs. So we also had another program where doctors were sent from Ghana to US, the ASCO initiative, to let them learn best practices in those countries. Then they can come and implement them. So what we are looking at is to improve patient outcomes. Then they adapt and then they localize the treatment guidelines, because what may work in the US may not necessarily work here because of so many factors. So those are some of the things that we did. Then I am proud to say that Pfizer was the one behind, sponsored the BISAYEN project. Yeah, so it was also an RFP, the request for proposals. So we put it out there. We went through the proposals, and these two organizations were the ones that won because they had an amazing project in mind. And the whole idea was to ensure that the patients are not left out. The education and everything is going up. And I must congratulate the team because I chanced on them when I was visiting Tamale, and I was very impressed with the work that they do. I know the project is supposed to end this year. We will discuss with the global team to see if it's something that we can continue as long as Accord is in Ghana. So finally, we at Pfizer, we acknowledge that the medicines availability is not the only problem in Ghana. We cannot address it alone either way, but we are collaborating with governments, NGOs, medical associations like you, to ensure that both our regulatory pathways, supply chain, and healthcare workforce, they are all developed. As I said, we may not get to the US level or the UK level, but at least we can get it to a level that also befits us so that we can stand out in Ghana when we talk of the sub-Saharan Africa or we talk of West Africa as a whole. So please, I hope that we'll continue this collaboration and then we will improve patients' care in breast cancer. So thank you very much.
Thank you so much, Regina. Thank you.
Thank you very much, Pfizer. And I would want to put in a word for BISAYEN. We are extending the program for another 5 years. Okay. So shall we invite the speakers? We'll now devote about 20 minutes to questions, comments, contributions. Please let us integrate depth with brevity. By that I mean very little English, more content, so we save time. Thank you very much. Is there another microphone? Okay. So can somebody pick that microphone and then you signal us, you introduce yourself, and then you ask your question. Thank you.
Thank you very much. I'm Dr. Nyako, first year resident at the Kolebu Teaching Hospital, Family Medicine. Thank you for the presentation. My question is for the last speaker about the referral for patients who come in with a major sudden paralysis when we are suspecting the cause being from the spread of the cancer. I want to find out, do we refer them straight to the emergency or to your department? And secondly, are there any arrangements for them such that when they get to the emergency or wherever they get to, there will be somebody there to take care of such people? Since you said within 24 hours we will be able to help that individual. Thank you.
Let's take 2 more and then
Thank you very much. My name is Mordecai Osu, specialist family physician at Kolebu. I have two questions. I want to ask, so if a premenopausal patient is on tamoxifen, when she becomes menopausal, do you switch the therapy for her? And my second question is about addressing patients who have spiritual challenges. You realize that no matter how educated an individual is, once they have diagnosed with cancer, their first option is to always seek alternate treatment, either in the church or traditional medicine. How do we still enlighten them? Because I've had this experience even in church. Last year, I did a lot of awareness during the month of October. And unfortunately, somebody was living with the cancer and had prayed and fasted and said she had been cured. Only to find out earlier this year that she had a big ulcer which is bleeding and she was doing alternate treatments. And I was wondering why she had delayed in seeking care. So how do you address this thing with people who are even learned, but they still have difficulty getting medical care? Thank you.
Thank you very much, the presenters, for a wonderful presentation. Mine has to do with clarification with Dr. Yongo concerning the wearing of brazier with wires under them. If she can explain better for us, because I also heard that wearing that type of brazier constricts the blood vessels over there, which rather dispose the place to or make it more prone to breast cancer. So I want a clarification on that. And then secondly, I want to find out what is the way forward concerning patients who are diagnosed with cancer. Any plans to make a ward, permanent ward for them, because they go through a lot. This one will say, it's not my case, it's not my case. They roam, and at the end, a whole lot. So if there is anything, like a beautiful edifice they made for the nephrology, if something like that for them, and or it's in the pipeline. Thank you.
Thank you very much.
Yes, so I would want to. Hello? Okay.
Yeah, I think it's okay.
The first question was what to do when you encounter patients with sudden paralysis. So what happens is that when referrals come to the department, all the referrals that come, there's a doctor on duty that reviews every department and every referral and books an appointment. So once a referral comes to oncology, the specialist on duty reviews the referral, and the aim of that review is to determine if there's an oncological emergency or not. So oncological emergencies are bleeding, brain metastasis called compression, superior vena cava syndrome. We have these ones are oncological emergencies, and once the referral is explicit, they are supposed to come directly to the oncology department. And what you can do is that once you see the patient, if it happened just, let's say, this morning, you would impress upon them to do an MRI, because it's only with the MRI that we can find which area has the compression. Sometimes the patients cannot afford it, and we have to do an X-ray and find a way, using clinical skills, find the possible area where the compression is, and then the patients can have radiotherapy. You have, as I said, it's up to 72 hours. At 24 hours to 72 hours, the reversal is about 90%. After 1 week, it goes down to about 20% because of the compression. Yes, so just refer to the department. Sometimes at the emergency, they are delayed. So these are the oncological emergencies I mentioned. And then the premenopausal. So for the premenopausal women that are put on tamoxifen, initially was 5 years, but there's new evidence that the benefit goes all the way to 10 years. We are slowly moving to 10 years. So you find a patient that maybe is around 47, and we start on tamoxifen. And we monitor. So once they stop having their period, we give them up to a year. And then we do the hormonal assessment that confirms that they are really menopausal. Then we switch to arimidex. We want them to have a total of at least 7 years. So if the patient has had tamoxifen for, let's say, 3 years, we switch and then they continue arimidex for another 4. Sometimes the patients are around perimenopausal, you are not able to tell. So we let them go on the tamoxifen for them to stop their period for a full year before we do the test to confirm. Then we switch to arimidex.
Okay, so I'm sure I'll take on the question that had to do with patient with spiritual beliefs. I think that whether we like it or not, we are all spiritual. And until you probably find yourself in a situation where you really want to, leverage on your spirituality, you probably may not, appreciate where the patients are coming from. I think that as a general principle, if whatever the patient wants to do does not really conflict with our evidence, based, practice, I think we should accommodate it. I think many years ago at a polyclinic, I had an experience where a young boy was very ill. This was not breast cancer, but boy with severe sepsis. And the relations said, no, this is not a hospital disease in quote. So they were actually taking him out of the hospital to a prayer camp. And I think they had spoken to, I don't know whether it was an orderly or somebody who had told them that they need to come with a letter. So the letter was already ready. They actually presented it, that they want the boy to be discharged. And we knew that this boy was going to die, definitely going to die if he should live. We practically begged them that we will actually allow whoever is a spiritualist to actually come and pray on the ward. So we actually made that effort. The person will come very early in the morning, come and pray for the boy, and then go. We did that for a couple of days, whilst we also continued with our treatment. Eventually, the boy got better, and the feedback that I got was that, they feel it's a spiritualist who has done a good job, which is okay, because as far as we are concerned, we just want the good outcome for the patient. So I think these are probably some of the ways that we may have to go, the extra mile we may have to go to accommodate, such patients. But then for a patient who says that they have been cured, I think as much as possible we should encourage them that yes, we don't dispute the fact that God is able to heal and all of that. But we also believe that when you are healed, there will be evidence. So let's encourage them to go for a testing and, get some clearance from their clinician, rather than say that I am healed. Because if you are healed, at least we should all see. Go for some form of testing and then let it be clear. And in so doing, hopefully we may be able to convince, some of them. Thank you.
Okay, so for the underwire brass, what it is that there's no study that has been done to prove it. But like you mentioned, some people think that, with the bra down there, it reduces or slows lymph flow. But if you look at the pathophysiology or what happens, it has to do with mutations and not necessarily flow. So there's no study or research that has been done to that effect. But they also advise that when you wear a bra, it should be a bra that the wire is flatly lying on your rib cage and not tightly on your breast. But not necessarily because it will cause. But if you wear bra, you know that it can mark you and give you some kind of scar or something, but not that it will cause the cancer. Thank you.
Yeah, I wanted to address the wards. So the question about the permanent wards, it's yes and no. I know that, I don't know if we are all aware, but if you've been active with maybe in your department with management, you know that there are plans to rebuild Kolebu, a whole new Kolebu, if they've been to your department to assess what your needs are. So I know there are plans to totally renovate the hospital, and there are plans they're in the pipeline. There are plans for oncology ward. I don't know, are you talking about a hospice or oncology ward? Because then there are two things. There are hospices where I don't know if I'm getting it wrong, terminally ill patients are admitted and given the support. But oncology ward, we will die. Oh. We cannot have an oncology. We cannot have an oncology ward. So we have some of our patients are surgical, we have some of our patients are pediatrics, we have some of our patients are urology. You know, we run across, oncology runs across. We have patients, neuro, I mean, every aspect of ENT, maxillofacial, every aspect of medicine, you have oncology there. So what happens is that these sites keep the patients, let's say for breast, they have the ward for urology, and then they come to us for chemotherapy and all. And we have a small ward where we keep patients, let's say, if they have neutropenia. But it will be impossible to keep patients for chemotherapy and admit them because we administer chemotherapy sometimes 70, 80 patients a day. And some of them are getting maybe day 1, day 2, day 3. It's almost impossible to have a ward. Everywhere in the world, it's an outpatient. You may have a ward for emergencies and critically ill patients, but not an oncology ward for all oncology cases. It's almost impossible.
And just to add to what Dr. Dazi just said, yes, we are looking at breast cancer today, but we have different kinds of cancers. So the idea is that any patient with cancer should have their primary doctor. So it can be the surgeon, it can be the hematologist, it can be any doctor who is been trained to manage that kind of cancer. Then, because we are also looking at the concept of multidisciplinary care. So if it's, let's say, colorectal cancer, and the patient requires the services of, let's say, a palliative care physician, or require the services of, let's say, an internist, they could go over and then manage such patient or help in managing such patients. But then I think that if you are looking at terminally ill patients, then that's where the hospice comes in. And I think that is an area where, as far as, Ghana's health system, we really don't have, hospice services. We actually have patients who come to the polyclinic, at other departments, who actually require hospice services. And that's where usually the challenge comes in, because people are a bit hesitant in admitting such a patient, because the question is that to what end? And then you have, managers who are concerned about the patient lying in the bed for so many days. You have somebody like Dr. Nketia who will be concerned that we'll be losing revenue, and all of that. So I think the solution is to have a hospice, services where such patients can, be managed over there until such a time when they have to go and meet their maker. Thank you.
Thank you very much. The next round of questions. Please, let's do this quickly.
So let me.
Thank you. Good evening. For someone like me who is not a medical person, I would want to know, so if I know someone who has breast cancer in early detection and the person is not willing to go to the hospital because of financial constraints, what should be my advice to such a person? And also, I want to know, I think no one spoke about maybe government policies on some of these issues, breast cancer. So is there any promising government policy on breast cancer or for breast cancer patients? Because we know the challenges that you face treating these patients. Yeah, thank you.
Good evening to you all. I'm Harriet from Dansoman Polyclinic. I wanted to ask if there are options for patients who have family history of breast cancer and probably want to have a radical surgery, because I've heard in other areas where people who have family history of breast cancer would want the tissues removed, and so they don't suffer the rest of breast cancer. Thank you.
I'm David from Gap Health Insurance. From the presentations, I realized that the church plays a crucial role in orientation and so many things that relates to our well-being. I want to find out, is there a conscious means to leverage on the church in creating awareness? And if there is such, how has it been in the past? If there is none, then I want to encourage that we use the church medium as a way of creating more awareness, not just in the month of October, but also first draw attention to these health conditions, and also, more importantly, in the month of October, do more awareness creation and even more of the screenings to encourage people and also get a better health. Thank you.
Thank you very much. So,
Dr. Note, please. I think you have 2 questions online, so we just want to add them.
So, Bernadette Kumsin asked, can breast cancer spread through breast milk to a toddler? What will happen if a toddler or a partner mistakenly sucks the discharge that flows from the nipple due to breast cancer? Can a toddler be infected if he or she bites a nipple that has been infected with breast cancer and perhaps swallow the blood during breastfeeding? Okay. And then John Mensah asks, how significant does excessive patient backlogs in terms of patients being seen and having their treatment started delay treatment, and what is being done to address this?
Okay, so I'll attempt some of the questions that will have been addressed to me. So with the question that looked at financial constraints, just like I mentioned in my presentation, for me that seems like one of the biggest, barriers and challenges with respect to access to breast cancer care. And in terms of what you can do, I think the person should start with having an NHIS, okay? In as much as we've highlighted the point that NHIS has its own limitations, it can sort of cover some preliminary aspects of the person's breast cancer care. So for example, surgery, okay? It should be able to cover surgery, it should be able to cover some medications. So I think the person should start from there, and then hopefully maybe some NGOs, some support groups can also come on board. Every now and then you do get people who are willing to sort of support, patients who fit into that kind of category. So I think that taking the initial step will be my advice for such a patient. In terms of government policy, I don't think there is any current, government policy for just breast cancer per se. But you know that recently the president has launched the Mahama Care, which is focusing on chronic diseases, non-communicable diseases, sorry. And breast cancer is one of the non-communicable diseases. So I'm sure we are in the early days, so we are not too sure in terms of the implementation and all of that. But I'm tempted to believe that something will be done with respect to breast cancer. Then the question about whether we involve religious groups and all of that, I am of the opinion that to strongly advocate, for breast cancer in terms of creating awareness, early detection, and all of that, it should go beyond the four corners of the consulting room. A lot of the work lies in the community, because you go into the community, you interact with people, and you are amazed, the kind of misconceptions, the kind of myths and all of that that they have. And we should also bear in mind that there are a lot of people who will never come to the hospital. So if we are waiting for people to come to the hospital, then we are going to miss it. And that's why I'm very happy with the concept of community-oriented primary care in family medicine, where the idea is that you don't just sit in the consulting room, wait for patients who are ill to come. As a clinician or as a healthcare team, you can proactively go into the community And then that is where you are able to reach out. We've done some community activations where we've been able to pick, breast lumps and have been able to direct patients to the right, referral centers. But then, in the nutshell, I think that in terms of the approach, it should be a multi-pronged, approach. So the church is important, community leaders important, media is important. We need to sort of capitalize on every opportunity that we get to create the awareness. And yes, I agree very much that it should go beyond October. So we shouldn't just make the noise in October and then there should be a sustained, deliberate, strategy to make sure that we create, awareness, with every opportunity that we get. And that is what we try to do with BISAYEM.
Okay, so that's for Bernadette's question. So breastfeeding a toddler doesn't transmit breast cancer in any way into the toddler. In fact, breastfeeding is actually very protective. And it's interesting to note that, as a mother who is doing breastfeeding, as you breastfeed and as you bond with your baby, you should even really look critical even at your breast. It gives you that opportunity to look at it, to be able to, eyeball it well to see if everything is actually all right. So it's like a 2-in-1 help rather. And then also with the partners, it's rather sometimes partners through palpation have picked up breast lumps from their wives, but to get the cancer from, what do you call it? From the nipple, no, there's no evidence to that effect. Thank you.
Just to add to the financial bit, it would be good to advise the friend that usually if it's early, the treatment is not that intensive, and so is less expensive than in the advanced stages. So when you pick it early, you treat it early, it's actually cheaper. Okay, and as he mentioned, there are a lot of support. Once in a while, you find people coming in to ask for patients they can help. And usually, for some patients, once they come and they hear of the cost, they just back away. I've had one patient who kept on coming, Dr. Minisika. So kept on coming, and the moment a company came wanting to support, she was the first person that came to mind because she was on my neck every day. She wanted to have the treatment. She didn't have the money. She's always coming, asking, isn't there any help? So once donation came, I quickly submitted her name and she had her treatment. So she shouldn't just stay home. You wouldn't get help if you just stay home. I think there's a question about the delays. So yes, to an extent, cancer treatment is structured and outcomes are better once the structures are followed. There's time for benefits for each therapy. And when a lot of time elapses, the benefit is very little. So as I mentioned, like radiotherapy, ideally between max 6 weeks, the patient should have radiotherapy. So if a patient is delaying for up to 6 months or a year, it definitely affects outcomes. And we see it a lot. Patients waiting for radiotherapy, then they come, they tell you, there's something on my chest. And then you look and there's local recurrence. It's often. And what are we doing about it? Again, as my brother mentioned, Mahama cares. Yes, we've been promised new machines, and we are hoping that it will go a long way to help and reduce the wait time. And hopefully some other PPPs, we are a lot of discussions are going on. We are hoping it's not just discussions, but they would become reality so that we can see the benefits.
So the last round of questions, because we are behind time. Yes. Finish. So I believe that we can say without fear of equivocation that we've had very, very erudite presentation. And we will leave this place very well informed. And we're going to be advocates of breast cancer care. The first presentation was on overview and screening of breast cancer. And it is quite clear to us that there is a lot of work to be done, because if about 50 to 70% of cases that present are already in the late stage, then all these benefits that could accrue to patients with breast cancer would have been lost. If you present early, it's less expensive to treat. You present late, then it becomes very expensive, and then of course the full benefits will not be accrued to you. Of course, the reasons are also quite clear. The myths are out there, and we need the social scientists to help in changing behavior and perceptions of our people. The second presentation was on dealing with the patient, or what I would say, dealing with the patient factor in breast cancer care. And it was quite clear to us that you cannot achieve much without paying attention to the illness experience. And if you want any condition that calls for biopsychosocial approach to care, then breast cancer stands out, because a person afflicted with breast cancer has lots of psychological problems, social, and even financial. And once again, we also know that the financial is a big hurdle in our environment. But like the last speaker said, we should not judge the drink by the look of the bottle. Somebody may come very unassuming, and you may be thinking that the person is at the pit of poverty. But once you engage with the person, you may realize that the person may have very good support system that they can fall on for help. Then came the final presentation that was on current trends, and we were treated to a lot of information. For me, what was clear was that one fits all to personalized care. Every cancer diagnosis requires drilling down to the molecule to know exactly which treatment option will be best suited for the patient. I would go back, take the textbook, read and upgrade my knowledge. It is quite clear that with Pfizer, are you there? Yeah. Yes, we are covered. Because we've been told the significant reductions that they have agreed to in terms of the otherwise very, very expensive and effective medications. I'm not going to try to summarize the fine details of the treatment trends, but what we have to know is that they are there, and you also have to know that it's really criminal for one doctor to stay in his corner and say he's treating cancer. Those days are far gone. The in thing now is a multidisciplinary team approach to treatment of cancer. I would also want to say that our colleague from National Health Insurance raised a point which is very, very important. You know, religious institutions are very much trusted. I mean, they have more influence on their church members than even husbands and parents have over their children. So we should begin to appreciate that and partner with them to effect the behavior change, to find a way of letting our citizenry get to appreciate what the trends are and what can be done for them. Let me end by saying that for every patient with breast cancer that shows up in the hospital, there are a number of them in the community who, for various reasons, including myths, including financial, including religious reasons, are not showing up. So, Dr. Amu, we would want to see many more of institutions or NGOs following your footsteps to hit the community, to really bring about the awareness needed. That is our best bet, you know, because if 15% is what happens in the advanced world, that is those presenting with late stage cancer, is in the region of 10-15%, and we are still hovering around 70%, then there's a lot of work to be done. So, colleagues, let's together say a big thank you to our presenters, a big thank you to Pfizer, and a big thank you to ourselves for making time to be here today. And then, of course, Sofpog. Yes, very powerful Sofpog. You know, so continue to champion the cause of our women. Thank you very much.
Thank you very much, our able chair, Dr. David Norte, for chairing this section, this seminar for us. I'm sure that we've all been equipped to be able to help the advocacy and also to help bring down the breast cancer prevalence and also to help with the care. We also want to appreciate our own, so that's also for Mame Mariandazi for the nice, she didn't want me to say that, but I mean, I have to. For this presentation, my own brother, Dr. Gordon Amo Debisaye Guru, for his presentation, and my sister, Dr. Ayongo Anan, for the presentation. Thank you so much. We really appreciate this one. We also want to take the opportunity to appreciate everyone here. We have a team from 37 Military Hospital. I'm sure 37 is privileged to have you, and I'm sure that it's going to be the message is going to be thrown out there. Our team from Rich Hospital, our team from Trust Hospital, our team from the Police Hospital, the team from Yahoo Medical Center, our team from Dansman Polyclinic, the Bisayan team, our team from Breast Society, our team from Achimota, the team from GHIC, that is Gap Health Private Insurance. I mean, they are doing great things out there. And we appreciate, I'm sure that they've seen a number of people who have received breast cancer care, and I know about it. We really appreciate you as well. The almighty Kolebu, are you here? Yeah. So the Kolebu team, we appreciate you for coming through. We have the Kolebu palliative care. I'm sure they talked a lot about palliative care. The whole Ghana, the palliative care team is at my department. So please, if you want to have care, you better see me, otherwise you are not going to have care. Palliative care team, are you here? Give me a wave, give me a wave, give me a wave. Great. So the whole Ghana, the training is at my department, and if you want to receive care, please, you have to knock at my door to make sure that you can receive the care. So we thank all of you for coming through. I think from here we're going to have dinner. Let's interact. Let's share ideas. Let's know ourselves better. Because next year we are coming here again. But the plea, I don't know whether Pfizer is here. Thank you so much. I wanted to end with you because there is a plea that some of us are growing and our prostates are getting big. But unfortunately, it looks like the men are being ignored. So there's a plea that next year you also will help with the advocacy for prostate cancer. I hope that we have your pledge for that. Pfizer, your pledge for that. Hey, I'm not getting that wave. Okay, that's a good wave. She's not saying no, she's getting, yeah. So hopefully next year we're going to have prostate cancer as well. So thank you so much. Shall we please say a word of prayer so that we can go and have our dinner? Shall we pray? And so, Father, we thank you for such a section that we've shared knowledge that is going to help, oh God, with the care of breast cancer in the country. It's improving, and we know that with this, it's going to improve even better. We know that, oh God, the message is going to go out there, and all our clients who are known to have breast cancer, and those who are yet to be diagnosed, can have all the benefits of this seminar. We thank you, we bless you, we appreciate it. We pray that even as we live here, we are not leaving your presence. Be with us, take us to our home safely, and continue to let us think about breast cancer even as we help our clients. We appreciate your help of taking us through this. In Jesus' name, amen. Amen. So I'll hand over to our able president so that she say a final word.
Okay, thank you so much for coming. We truly appreciate you. Please, dinner will be served in the restaurant. You actually pass through there to come here. So as you go out on your left, you get there, you present your coupon, and then you will be served. And my special ladies at the back, please, I'm working with you, so you are not left out. Thank you so much.
Thank you. Thank you so much.
This one. Where is it?
How's it going? You might go short, but you go use too much. That's what people. I don't think I think go use 2 months. It's 2 months, eh? Okay. So, but will you go? Can you hear? I thought you were going to do. Yeah. I want to do it. You're taking you were the first person to come. So, should I use this one? Should I use your small mic? No, it's like that. Okay. Oh, yes. Like, you're taking from this. Okay.
Hello.
Hi,
So please your name.
my name is Dr. Harriet Kanlisi. I'm a second year resident in family medicine at Greater Accra Regional Hospital.
So we want to know your take home from today's program.
I'd say it was a very excellent symposium. I learned quite a lot. It was great to get the opportunity to see what the current trends in breast cancer treatments are. Sometimes we tend to see our patients and think that they may not be able to afford the things that are out there. So it's great to know all the work that is being done, to know that there are options, treatment options out there that previously may not have been accessible because of cost, but now it's accessible. So we should explore these options for our patients. It's also, I also learned that there are companies out there, like the sponsors for today, who are willing to help our patients. So there's treatment options. We should make it available. We should educate our patients. Hopefully, we'll be able to get them to come in early, and our treatment outcomes will be much better than we've seen previously. So it's very encouraging, and I enjoyed the experience. I'm glad I got a chance to come in.
Thank you very much. All right.
A quick take, okay.
When a senior house officer is going,
what do you call it?
Mariam.
Yes, I still have the pictures.
Susan.
Okay, who may be some question? I don't know.
the way of boss class.
Oh.
What should I even say?
Hey,
You
boss.
see your take home.
My take home is.
What do you have?
I say, I don't need to introduce myself.
Do you want to? Do you want to?
I don't know.
Okay.
Hello.
Hello.
My name is Dr. Susan Keteku. I'm a family medicine physician. I'm with Kolebu Polyclinic Family Medicine Center and also a part of the Accra team for BSIN.
So you're most welcome and thank you for coming through. Just want to know your take-home message from today. What do you have for us? What did you take from this seminar or symposium?
Okay, so for me, the take home is the patient is at the center of our care. In terms of breast cancer care, it's not one size fits all. A lot of the new trends in management has to be tailored based on the findings we get from biopsies and so on. And it's a multidisciplinary approach. So I'm proud to continue my part in primary care, offering primary care, and then also in terms of patients' education and creating awareness.
Thank you very much.
Thank you.
Okay, enjoy your evening.
You too.
Are we okay?
Yeah, thank you. Any more? No. Thank you very much.
One more. Pardon? Say the president. Okay, friends, no. Then say she go to the restaurant too. Oh, she go to the restaurant. Then say she go to the restaurant. Let me see if she's outside. Okay. Could you? You don't like camera. I don't like camera. So ask them.
Okay, so I'll just ask like your name and where you are, what you do, and then your take home from this. So,
Ready.
Okay. So good evening.
Good evening.
Yes, so just a brief introduction who you are.
Yes, my name is Dr. Adoma Piadankwa, first year resident at Kolebu Teaching Hospital. Yeah.
Yeah. So you're most welcome. Want to know your take
Thank
home
you.
from today's symposium.
Okay, so I think that it was a great symposium. We've got to learn more about breast cancer. A lot of the myths that were in people's minds have been debunked. Also, I think that the availability of certain medications has opened the scope for treatment. So we know that there's hope for the treatment of breast cancer in Ghana, and we know that we'll be able to pick it up early and then share this knowledge with our patients. Yes, thank you.
So thank you very much.
Thank you too.
All right.
Shots. He doesn't like camera, so we'll talk plenty. Thank you very much, boss. You got your stuff right. Yes. Take care. Okay.